So now, how do we support Canadians in eating healthy? Because I will say it isn't easy. It is an effort. It requires planning. It requires preparation. It requires a lot of hands-on work and help. It also starts with our support systems that provide us with the information, us as consumers, about what it is that we're eating. So Health Canada recently changed the nutrition facts labels as well as the ingredient list labels on Canadian products. So some products you may already see the change, some are in transition, but I think this is huge. So if you look at the new facts label here, it's actually not only going to tell you how much sugar is in a product or how many calories there are per serving. You've got to pay attention to the serving. It could be 10 cookies or it could be 2 cookies, all right? But it's going to tell you the percent daily value of sugar. And down here at the bottom, if you guys take your magnifying glasses with you grocery shopping, you might be able to see this little disclaimer that says, if it's greater than 15% daily value, that's considered a lot, meaning it's contributing to a lot of sugar that you may or may not need. And that may make you reflect on the purchase and maybe not even buy the product. Okay. But you want to be mindful of food labeling and you want to be mindful of advertising because sometimes some food products are going to make a statement such as maybe low fat or high fiber, but you want to confirm that not only with the nutrition facts label, you want to look at the ingredient list. So the way it works in Canada, according to food labeling regulations, the first ingredient is the most abundant by weight, okay? And then it just continues to the least abundant by weight. So this product here has a lot of sugar in it because it's the most abundant ingredient. And then it's got a little bit of spices there, which may be negligible. And this is usually where you find a lot of the fillers. This is where you'll find artificial flavors, preservatives, emulsifiers, the things that make, food look pretty on the shelf. I like to use salad dressing as an example because not only might it be calorie dense, not only might it be high in fat, but it's got a lot of additives in it that relates back to the recommendations to say you want to eat wholesome real foods as much as possible. Okay. So when you look at that pretty salad dressing that's got, that nice uniform color and texture, that's because it's had a lot of stuff added to it. When you make salad dressing at home, your oil and your vinegar don't like each other. Yeah. They kind of float on top of each other. It might not look as pretty, but it doesn't matter because it tastes good and it's real raw food. Okay. There's a lot to be said about this. There's even a lot to be said about public policy, how we can change school programs, how we can change medical lifestyle programs and, increase that need. This is where, like the panel today, we're a multidisciplinary team. We all support each other in terms of our initiatives and goals and education and advocacy, but we need more. So, we also need Canadians to say we need more help or we need more information. This is how we can make a change. And so I'd just like to say that you can achieve eating well, you can achieve weight loss, you can support individuals with NAFLD, NASH, but we want to make sure that it's not only evidence-based, we want to make sure that it's sustained so that those risks are also mediated later in life. And just before I circle back to Dr. Kehar, because I'm mindful of time, just in case you want some other ideas to support, strategies around healthy eating, there's lots of information out there, and the Fatty Liver Alliance will be sure to share all of that with all of you. So thank you for that. Oh, those are all the references in case anyone's interested, I should say. But I'll hand it over to Dr. Kehar right now to continue educating everyone about NAFLD NASH.
Oh, you're on mute.
Thanks, Inez. Yeah, so I'll start with this slide. I love it. So, sugar is more dangerous than gunpowder. So Just to one more point on the diet, I get this question a lot from patients, parents. Is diet beverage okay? Unfortunately, because of obvious reasons, there is not a whole bunch of human data around that. But the mice studies definitely have seen that it does lead to a lot of oxidative liver injury. And in rodent studies, there have been instances of high liver enzymes and lipid even with diet beverages, which contains aspartame, which is like 160 times more sweet than sugar. So as Inez mentioned, water it is. A few things on physical exercise, because we now know that asking patients just to go home and lose weight, it never helps. So you need to give them some examples and help them attain their goals, basically. So as all the goals, we should try to achieve SMART goals, which are specific, measurable, achievable, relevant, and timely. So everybody should be given like a time frame. This is how you're going to do it. This is how it should be done. And then ask the kid, right, how confident are you? Give them an action plan and ask them, like, what are the barriers, right? What if there is a social barrier, if there is a financial barrier? We can keep educating them about Mediterranean diet, and whole a lot of diets. But the reality is there is a lot of food insecurity which comes into play in obesity and pediatric NAFLD, right? If somebody is eating out of food bank, unfortunately it's really hard for them to incorporate all these choices. So you need to have a patient as a whole and understand their psychology, their social life, and then help them. And then giving them some coping plans, like what if that this doesn't work, right? So just talking through and motivating them. So something which I sometimes share is walk to work, walk to school, get off your bus one stop earlier, just walk that 10-15 minutes extra. Break up sitting time, right? If you're sitting on a chair and working, just after half an hour, just go for a small walk. Dog walks, walking groups, gardening, even lawn mowing. So we know that these short bouts of activities have probably a same effect as you do gym for 1 hour, right? So more done over a day is the better. And then now there is a data coming that if you do even don't lose weight by doing all these lifestyle changes, it does have positive metabolic outcomes. So just keep doing it. And we know that in various systemic analysis and meta-analysis, that diet and exercise, they work together and they work best together. And I said that, though go home and lose weight, does it help? Unfortunately not. There have been multiple studies showing that we need to encourage patients, we need to motivate them. There have been multiple studies that if you're seeing patients 1 year versus every 3 months, the patients who are you are seeing every 3 months are going to lose weight. They have improvement in their liver enzymes. So you're putting the patient accountable and you're continuing to motivate that, right? And then this has been shown in a study that Dr. Mozaki did it at Sikkis as well, that if you see them every 3 monthly in pediatrics versus every annually, there is definitely improvement if you see them more often. And you also screen for their comorbidities every time you see them. And the labs are repeated depending. So as Ines mentioned, that lifestyle works, but unfortunately the problem is that if you lose 10% of body weight, we know you can lose 90%. There can be resolution of 90% of NASH. There is also improvement in fibrosis as well as steatosis. But if you track these patients for a year, only 10% are going to continue to lose weight. So that's a whole problem. So unfortunately, there is no current available treatment to or supplements to treat NAFLD, whether it's adult or pediatrics. But there is like $1 billion industry currently working on. There are several drugs in pipeline. So we hope down the road in next few years we will be able to have some medication which we can provide to these patients, whether it's one medication or combo, because of recent interest in combo therapy in NAFLD. And then we also need to understand that NAFLD is not a pediatric hepatology problem. It's a public health problem, right? So we need to engage primary care health providers, other specialists, and we need to engage policymakers. So recently there was a consensus statement that was published from Lazarus group in Nature, which suggested that no country, I think apart from India, which have like a policy for NAFLD. Most of the countries don't include NAFLD in non-communicable diseases prevention, right? So there is no funding. So that's the whole other problem. So where do I feel, the future of NAFLD is, we need to further engage other primary care health providers. We need to screen these patients early. We also need to reduce this healthcare bias around weight, right? Because of funding issues. And in healthcare, we all have our own mind frame with all our biases. We need to reduce that. We need to have a comprehensive integrated management, right? And how to approach these children. In adults, there have been, FIB4, which you can use in community setting to screen your patients, whether they are at high risk of having fibrosis. Unfortunately, there is nothing of that sort in pediatrics. We don't know who is a group of patients who are going to be seeing me in a tertiary care center, or who can continue to work in a community with a primary care health provider. We need more work on non-invasive biomarkers, therapeutics, and I think the eventual endpoint is going to be some sort of personal medicine, because NAFLD is such a heterogeneous disease. Not two patients are similar. They don't behave similar in natural progression. They don't behave similar when you take about therapeutics and how they improve with all these medications. There is so much we need to learn further. And I think genetics, microbiome signatures may give us some answers down the road. And then to take home, NAFLD is highly prevalent. It can occur in young children and even in lean children, as Ines mentioned. It can progress rapidly. Lifestyle intervention is the only effective treatment. And there are multiple therapeutic which are currently in the pipeline. And hopefully in the next few years, we'll have some effective treatment for this condition outside lifestyle management. Thank you. And I'd be happy to take any questions.
Well, I'll start by saying, first of all, your presentations were very different and so insightful and helpful for people. I am sure, like, there was so much information in a short period of time that there's going to be enough to talk about for people to have different interests and still get a lot out of it, for sure. I was wondering if you were thinking about the world in a natural way. There are parents who can see in their children already that they're well, somewhere between overweight and obese. And, and as you said, that they're going to grow over time. And one strategy is to maintain the weight as they grow. And that's one. If you see that, kids are overweight to start with, should you go to your pediatrician as a parent and say, hey, I'm sensitive to the fact that fatty liver disease is out there. Probably, by the way, over the last couple of years, even increasing more with COVID and people at home and all that stuff. So is it something I should be concerned about? Is there a test I can do to see if my son or daughter might have it or it might be at risk? So is that the start here? Like, where do we go?
Yeah, I think, because I said that the condition is asymptomatic, right? So unless you're going to damage your liver significantly and develop cirrhosis, there is no signs. So, the screening is the key. So currently the NASCAN guidelines that was last revised in 2017 suggests that if you have high risk like obesity, that is a body mass index over 95th percentile, these children should be screened using an ALT. And then, definitely, as I said before, the ALT target, which we are using for children, need to be age and gender specific, not the lab specific. And if your levels are normal and if the risk factor stays, then the suggested recommendation is that you need to screen these patients every 2 to 3 yearly, or sooner if there are additional of risk factor, right? If the patient with obesity develop type 2 diabetes, you're going to screen them sooner than that.
Mohit, sorry, before Inez, you respond. You said 22, I think, right, for the cutoff for
Yes.
kids. So
Yes.
do the labs, if you go to something like Life Labs as an example, does it specifically, is it set for the age that's on the lab tab?
Not a lot of labs outside the community do that. If you go to children hospitals, that usually they use sometime these cutoffs, but definitely we need to go, like for Canada we have the caliper data which have thousands of children, and they screen everybody who are normal and set our levels, so we could use something like that. But
That's
definitely.
Thank you for that. So that's great. You highlighted that.